Thank you for the lecture of Dr. Salman. So it's like a continuation, but it's non-surgical, okay? So last year my topic was how to avoid the molar widening when you're doing the mid-face scalp thread lifting. We know that Asian face, especially Filipino patients that I handle, because we have round shaped face, right? And when we do the lifting from the nasolabial towards this lateral cheek, we notice that it's widening the mid-face area. And I have patients who didn't want that effect because you already have a round face and you're further widening the mid-face, making the face further rounder and shorter. And so we discussed last year how to avoid that kind of mid-face widening. And we modified the vector, we modified the entry point area. So we had these samples of how to do your curve thread lifting on the mid-face. And then about same year, last year, it was in another conference, I think it was ASLS Bangkok, a delegate from the United States. He asked me if I was already applying the reverse method. So actually I told him I started doing some reverse method on the upper third of the face. And recently I checked on the Google also, okay? I saw some of these videos showing reverse method. So I realized there's a lot of people doing it. And I even saw a friend of mine, she's a nurse practitioner from San Diego, California. She was also doing the reverse, so the natural NP. Because in the States, the nurses and nurse practitioners are also doing the thread lifting. So when you also Google it, there's the definition of the reverse method. So it's doing an opposite to the traditional technique that we do with our curve lifting. So just a review of the different kinds of absorbable threads. The ones that we use, the polydioxanone, polycaprolactone, and poly-L-lactic acid. And they mainly differ on the longevity. How long do they last? Like the PDO can hydrolyze from 6 months onwards. Your PLLA could hydrolyze for about more than a year to 18 months. PCL, same thing, more than a year, even up to 24 months. So they are hydrolyzed, they're broken down into carbon dioxide and water, or hydroxyetoxyacetic molecule, okay? So that's the end product of this when they're degraded in the tissues. And in terms of the characteristics of the different absorbable threads that we use, so we have classified them. We have the mono or simple, we have those screw or the braided, we have the curved threads. So I started in 2010, 2011 utilizing the mono, the simple ones. And basically we want skin tightening, collagen stimulation. Then the braided threads, the screw or a thread coiled in a needle, they were telling us it can stimulate more fibroblasts. And then your curved threads, these are the ones that are for mechanical lifting. Then this is another classification. This is from Dr. Banwadi here from Bangkok. She shared it with me. So the main classifications, the non-barbed or floating type of threads. Then we also have the barbed type of threads. So basically here on the left, so you have your mono, your twisted, your braided, and then on the barbed type, they were subclassified as to the direction of the barbs. So you have the unidirectional, so one direction, you have the bidirectional, and then you also have the multiple bidirectional. And there's another subclassification as to the position of the barbs. They can be unilateral, one side, or bilateral, two sides, or 360 degrees spiral. And they also classify as to whether they are cutting type or molding type. Because before, they started with manually cutting those threads. Then there's also this molding where they use like a machine. It's kind of like a molding type of a machine. And then they also classified as to whether it's in a sharp needle or in a blunt cannula. So basically, the principles, like with your cog, you want to do your mechanical lifting, right? You want to grasp those ptotic tissues and reposition them upwards. So Dr. Salman already explained about the aging. Everything goes down from that triangle of youth to the so-called pyramid of age or square face. So the first one, the mechanical lift by your barbed threads, and the second one, your simple or braided threads, the so-called wound contraction phenomenon. So we have this mechanotransduction. So these are series of cellular responses. So there will be inflammatory cells coming in, and these cells will release some peptides, growth factors, and these growth factors will activate those senescent fibroblasts to synthesize again the collagens and extracellular matrix proteins. So if you look at this slide here, so like an illustration of what's going on. So you insert a foreign body. Normally there will be polymorphonuclear cells, your inflammatory cells. They will come in. They want to try to engulf the foreign material. Then they form these foreign body giant cells, and they will activate your senescent fibroblasts, and hence you have more of ECM proteins. And then another one is the so-called increase in your vascularity, the so-called neovascularization. That's another, like a histology that they've done, a study, an animal experiment. Once they insert these threads, they've seen also collagen proteins formed around the sutures. So these are histology that they showed to us. And then the fibrous bridging effect. So old fibrous collagen connecting with newly formed collagen. And they also had this illustration where the soft, or rather the subcutaneous tissue part kind of contracted, or there was like a 21% decrease in the subcutaneous fat layer. That's why when you do cog thread, instead of like making the face fatty, especially we have patients with really a lot of fats on the face, somehow we tell them this can have this 21 to 24% reduction in the fats. So this is another illustration they presented to us. And also, the increase in multiple growth factors. So those EGF, FGF, IGF, VEGF, there's an elevation of all these important cytokines for the fibroblast activation. So these are series of events. What's happening when you have threads inserted in your tissues, particularly in the subcutaneous part. So tissue contraction, cell signals, inflammatory process, fibroblast activation proliferation, collagen matrix formation, the fibrous bridging effect, wound contraction, and the facial shape change from the square or the pyramid to the inverted triangle of youth. So in summary, these are the effects. So in terms of the mechanism of action, neocollagenesis, neovascularization, increased MGFs, tissue adhesions, adipocytolysis. So let's go back to the aging again. So aging is all layers, all tissue layers. So from your epidermis, dermis, and then subcutaneous fats. So some of the superficial fats, they tend to just go down with the pull of gravity, right? And then some of the fat tissues, they atrophy, particularly the deep fats in the middle cheek compartment, they shrink. Then some of the fats, they just go down. And then also the bony tissues. You notice the orbital rim, there's like a widening superolaterally, inferolaterally. And then in your mid-face, the anteromedial maxilla piriform fossa, it becomes sunken. That's why the vector of that zygomatic arch to your orbital rim, from that horizontal vector, it becomes oblique vector. And there's also the chin retrusion. So when we age, your bone gets reabsorbed and the tissues above, they also further sag down. Okay? Then your retinacular cutis. So the retaining ligaments, as mentioned by Dr. Salman, okay? On the subcutaneous, you have these branches, the retinacular cutis. So as we age, what's happening with this retinacular cutis, they kind of weaken and lessen as well. So this retaining ligaments. And then, so the approach is multi-layered also. That's why we have injectables, we go onto the bone, or there are injectables, we go on the surface, depending on the product you need, or the rheological product or material. So the sandwich method, so different kinds of treatment modalities that you can apply for every layer. Okay, so if you need to rejuvenate dermo-epidermal layer, improve the skin quality, these are recommendations. You can combine injectables, devices, lasers, exosomes, regenerative molecules, collagen biostimulators, skin boosters. Okay. So for calf thread lifting, we want to reposition again on the mid-face maxillofacial, on the lower face, your jaw fats. So you want to target this. So this is Baker's aging classification. Like, who are the ideal candidates for the non-surgical? So of course, we have to refer the ones on this type 3, type 4, Dr. Salman. I'm gonna give them to you. So the ones that I can accept will be the mild to moderate sagginess, okay? So there you go, whether surgical, non-surgical, so choose the right candidate. So these are the ones that we wanna improve, so the sagginess, okay, the skin quality, we wanna improve all these conditions. Then, when you do this kind of treatment, we need to review our anatomy. Again, we are anatomists. You need to know the different tissue layers and which is the correct layer to place your threads. And which will be the danger layer, the no-go zone layer, the layer that you will avoid. And what are the structures that you will also avoid to prevent complications? Blood vessels, the facial nerve branches, salivary glands, because they're like calf thread lifting that they puncture the parotid gland or even the parotid duct. That's why tomorrow, let's do kind of a workshop and see all these layers. So your tissue layers, you have to know this. Then where do you anchor your threads? There should be something like a fixation point. Where do you fix them? Where do you hang them? So we have ligaments, connective tissues. These are strong or fixation areas, like the lateral part of the face. So we wanna fix our calf threads on this lateral because we have septa, we have connective tissues there, and this is mobile, the medial. Okay, so you have to understand these kinds of anatomical structures. So your retaining ligaments is like a tree, so connecting to the bone to the skin. So you have your true retaining ligament here. So safety, again, you have to stay in that safe plane. Well, in calf thread lifting, it's recommended to place it in the superficial fat layer. Although I know some surgeons, they do dual planes, superficial and deep plane. I'm not a surgeon, so I'm not going to go to the deep plane. So the superficial fat layer, so don't go, of course, beneath that. Don't go beneath the SMAS layer, where you have all these facial nerve branches, the blood vessels, glands. So avoid that layer. And those who are doing neck thread lifting, so you just stay at the subcutaneous plane above the platysma. If you go below the platysma, then you're gonna hit all these structures and cause complications. So some transverse section of like where will you place your threads, okay? So if you look at the subcutaneous fat layer, the yellow one, it's kind of like the safe plane to place your thread material. However, you also have to assess your patient's volume of tissues. What if the tissues are atrophic and you're using a COG? And take note, the COGs are thick. So if you have a patient with volume loss and atrophic skin, it's not ideal. So if they have volume loss, you have to restore volume first. So again, choosing the right candidate for this kind of treatment. So now my topic is more of like a methodology. It's more of like the technique aspect, okay? So the principles in reverse scalp treadlift. So it's the reverse of the traditional, the classic. It's an opposite vector. And they were saying that it's creating a stronger anchoring in lift. Although I always start with the traditional, with the classic. And I just kind of like add reverse in some cases. So it's a case-to-case basis with me. I asked my colleagues in Korea, most of them are doing the traditional. Okay. Although there are cases that I do the reverse. So your goal is, again, just reposition photic tissues from the lower to the upper. You're just bringing it back upwards, okay? So indications as your traditional, basically the same indications, upper, mid, lower face, or even the neck lifting. Now, who are the good candidates for your calf tread lifting? Those with mild to moderate or mild sagginess, okay? So those with enough tissues, enough volume, and then some mild depressions, and then some doctors I know they avoid patients with like very fibrotic skin issues, especially with calf tread lifting. We had a guest one time from Japan. We gave a model, but the model has a lot of severe acne, atrophic acne scars. And she was saying, no, I don't want her. She's not a good candidate. So much fibrosis. And the ideal shape, of course, if the shape of the face is square or like pyramid, those are ideal candidates. You want to reposition those photic tissues. So there are also contraindications. So who are the patients that you will not do this calf tread lifting? So of course, the very severe sagginess, really very photic face. We will refer to Dr. Sandman, okay? And again, the patients with too much volume loss, thin skin, atrophic skin, and if there are like cutaneous infections or comorbidities, I don't do non-surgical procedures on those patients who have active medical conditions and history of allergies to the components of your anesthesia or anything that you're going to use for that procedure. So these are not good candidates. Very too much, okay? So weight loss first, weight management, square shape face, so it depends. It's kind of relative. And then severe sagginess, loose and thin skin, deep skin fold. So we will refer to Dr. Sandman already. So now going to the techniques, the mapping. When you do this, you need to know what is your vector. What is my entry point? What is my end point? The target layer, the design, the pattern that I will follow, okay? So you have to do this mapping for your patient. It's important to assess your patient, okay? So it's not like one treatment for all. So patients have like, we vary in terms of our face shape and even in their desires, okay? So you have to do this mapping. Let me share my first case. Like last year, I presented her to you, a case of hypertrophic ptotic face, just wanting a natural rejuvenation. And I think last year I've shared the technical already. So I do many fox eye treadmill. In the Philippines, I don't know why they like the fox eye. Like Bella Hadid did the surgery, right, Dr. Salman? So patients come to me, doctor, can you do the fox eye treadmill? Okay. So most of my patients in the Philippines, they don't want the kind of angry bird. They just want slightly elevated on the corner of the eye. So I did the fox eye tread lift. I did the malar lifting, okay, with the entry points on this area of the zygomatic cutaneous ligament. And I also did the lifting or reverse method there. And then, so this was her picture. And I did some refinements, so nose thread lift and some lip filler and a little bit of braided threads on the nasolabial fold. And I shared her with you last year, right? So this is something natural, less is more. Natural is the key, simple is best. So she just want to look refreshed at her age. appropriate for her age. Now, a year later, so she followed up, actually last month. So this is her recently. So comparing to the original, she's still good looking, right? Now, she came back, of course, for some touch-up again, maintenance. She wanted to boost what I did. So this time I applied a reverse method. So on the forehead, still did the traditional, the classic, but on mid face and lower face, I tried, because I'm gonna give a lecture on this, so I said, let's try this on you. So I did that method, okay, again, the fox eye again. She's 50, I think she turned 58 now, okay? So it's reversing the aging. On the forehead, I still did the traditional, the classical, okay? So I'm starting with injecting lidocaine, and then I just follow the track of the trend. And then for this one, my favorite fox eye trend lift. It's more of an oblique approach, oblique vector, rather than the vertical from inferior to upper. Because most of my patients, they don't want to look like Angry Bird. So they're so concerned about that, okay? And then after that, of course, the mid, okay. So actually, I still combined a reverse brow couplet on her. So later I have a video on that. So now this one, the nasolabial, I just have two entry points, like 1 cm lateral to the nasolabial, and directed it towards the posterior zygomatic arch. Okay, and then for the marionette or the jowl area, two entry points towards the preauricular. So the entry points are marked as green dots here. Okay, so this is the design. Then I still did the reverse on the medial eyebrow because I was not satisfied with the classical. I kind of wanted to just push a bit the totic issues on the medial area there. So this was the design. And then we took a picture after and we checked on the, particularly the corner. So of course you have that lifting again of the corner of the eye, and then a week later she shared her photo with me. Okay, so this is a natural way of doing and maintaining her youthful look already, because she was already happy with the last year. She doesn't want to go back to that original photo. So some of the designs, like you have the classic, you have the reverse, you can have an entry point at the superior, this brow area, the eyebrow section. Then I think I shared this last year too. This was a reverse method demonstrated by Dr. Young Jin Park in Philippines. So his entry points were on this line, oblique line, from lateral canthus to the lower earlobe, 5 entry points. He used a fixation type of thread. We call it end fix. And so entry point here towards the temple region there. And he went on a deeper plane actually. You can hear him like there's a sound, cracking sound through the fascia. And I'm more of the deep subcutaneous layer, but he was sharing with us, he goes into the interfascial plane. Okay. So for me, I won't be doing that. So this was his method. He shared with us a reverse method. So actually, our goal was not to widen the mid-face, but do some lifting. So somehow, mid-face was not widened. And she needs more additional lifting treatment. Probably I'll refer him to Dr. Sang. But she's just mid-40s. Okay. So my favorite treatment, a simple reverse method of like lifting the corner of the eye here. This one just 3 simple entry points and towards its oblique vector. You can also do the vertical vector if your patient really want this. Okay? So it's a matter of what is the direction of your pull. So as simple as that. And then this was the result. Okay, so you notice the tail of the brow was just lifted. Okay. So if my patient will still want higher, you could still add more contrast if they want more. Okay. So this one is a combination of classic and the reverse method, and also this patient of mine only wants subtle result. So same technique as before. So there you go. So lifting of the tail of the brow. Now I also have this video from the Endfinder channel YouTube, okay? And I'm with the Endfinders too. So he has this demonstration of the full face reverse thread lifting. So this was like released in the year 2020 during the pandemic time. And imagine the entry points towards the scalp region. Okay, he was using double cock threads, a royal cock, and this one also entry point on the malar prominence towards the scalp area using fixation and double cock threads there. So his entry points are really not on the conventional entry points near the hairline that we do. And I think if you have entry points on this center part of the face, at least you're avoiding the hair strand and no incidents for any infections there. But he combined with classic. He still had the classic. He had this like on the jawline area, he still combined with the classic method. And I checked also on like a paper with this title Reverse and Antegrade Vector Thread Lifting Techniques for Nasolabial and Marionette. Okay, so they have the combination, the traditional as well as the reverse. Okay, so if you look at this one, the letter A is the traditional and the letter B and C the reverse approach. Okay, so it's in a crisscross pattern. Okay, so they did it on this 43-year-old patient, and you can see the lifting, the repositioning after doing that kind of design or pattern. But I noticed she had a mid-face whining because some of my patients don't want puffy mid-face, or they don't want the mid-face to be dominant. Okay, they want it within that balanced equal ratios, the upper, middle, and lower third. Okay, so this one also a combination again. This is for marionette lifting, but they have the letter D, the reverse. So the entry points are here towards that lateral canthal area, and they did it on this 53-year-old female, and there's the lifting, right? So these are this is the paper, and they concluded that that reverse method is an additional. Okay, they're not saying that it's the first one. Okay, it's like an added application or technique for doing procedures. So this is my guide. Whenever I see my patients, you have to assess them, analyze them, review your anatomy, make your design, and choose an appropriate thread material to apply for each of your patients. And these are like samples of designs. So there's the traditional, there's the classic. I would recommend when you do the reverse method, choose the right thread, appropriate thread. More of the fixation type of thread. Okay? Because we have different kinds of, like, if you have a bidirectional, this one is bidirectional, two directions. The center there, more tension there. That's why they were reporting with bidirectional. There's more of thread migration because kind of it breaks in this center there. And like when you have a multiple bidirectional, those short bidirectional threads, you're dispersing the stress on the thread. So you can grasp, you can hold, you can lift, reposition when you also have the multiple bidirectional. It's more of the fixation type. It's anchored well. Okay, so this one is a sample of the multiple bidirectionals, short bidirectionals there. This is a punching type, so fixation type. You can check on the appearance. Like I saw this on the
Using a
YouTube.
fine needle, the doctor inserts thin, dissolvable threads under the skin. These threads have tiny barbs that latch onto the underlying tissue. Once the threads are in place, the doctor gently pulls them upwards, lifting the eyebrows. The barbs anchor into the tissue, holding your skin in its new position. As the thread...
So basically that's the goal, right? You anchor those barbs. However, the barbs, like on the third month, because these are short barbs, so they kind of like become weaker, and they will hydrolyze already in 6 months. So what I do is to sustain the lifting, I also combine with those simple short screw threads to sustain the collagencies. Okay, because on the third month to 6th month, the cog lift, the lifting mechanical lift, they're gonna drop down again. So I still combine, or you can combine with your energy-based devices to sustain the effect. So it's like this one is an animation. So when patients age, so you see those soft tissues, they weaken, they go down, they sag, okay? So when you insert your calc thread, you want to reverse that aging process. So with the mechanical transduction effect, and you're kind of like restoring the original lifted look of your patient. So this is like in your subcutaneous layer, you place your PDO threads and you do your 5+ stimulation and you have fibrous bridging effects there. So in terms of the safety, because in my topic is it's safe, okay? So it's technique dependent. It depends on the injector. I believe that it's your job to have a safe procedure. Since it's a minimally invasive approach, okay, as compared to the surgery, more risk, okay, and still tissue friendly if you're using the PDO. I start teaching my students with PDO because PDO, 6 months, it goes away to 12 months. But if you start with PCL, PLA, if there's a complication, the complication is longer. If you're a beginner, start with the PDO. So again, the rest, it depends on the one doing it. So if you place it in the wrong plane, if you have wrong vector, or you call it asymmetry. So if you also place it too superficial, okay, so it will depend on how you do it, and you have to follow the aseptic technique as well to prevent any infections. And doing the right anatomical layer, you can avoid complications like this, okay. Sometimes you get dimpling, so what you can do is just massage, release that barb, because it kind of attached to the soft tissues, right? You just do like a releasing, or you can reinsert the cannula and just do kind of like you're subcising it, you're releasing it. And if there's like a visible thread or what do you call this, thread excluding, I would recommend just remove it to prevent the infection. Okay. So safety tips, again, choose the right patient. Blunt cannulas are recommended. Stay in the correct layer. Aseptic technique is critical, and also talk to your patients, inform them what to expect. So is it more advantageous to use the reverse? I still start with the classic, with the traditional. For me, the reverse is just like an adjunct, or if you want to push some more, then just add it, okay? So they were saying that it gives a more contouring effect. Again, it depends on your technique. Less risk of thread migration. It depends on the type of thread you're using. And still the collagenesis is still there, but you can add some more other treatment modalities like this to really give that good rejuvenation. So for me, the classic calc thread dip is still the gold standard for me. I just do reverse if needed, or if I want to push some more. And then the indications, and then combination is still the best. So know the aging pathophysiology, know your anatomy, and understand the clinical properties of the material you're using. How will they behave inside the tissues? Proper patient selection, acquire the skills, the techniques. Combination is still the best approach, and avoid your complications, and also know how to manage. Thank you so much. And I invite you to